Right. So, Imali, uh,
Good evening, dear madam and dear
yeah,
fellows. Today we are talking about the hypothyroidism guideline-based management.
on behalf of the College of Sri Lanka College of Specialist Family Physicians, huh? Right.
This is the patient I encountered during my family medicine appointment in Base Hospital, Panadura. A 15-year-old schoolgirl came with her mother to discuss the ultrasound scan report. She met her GP 1 month ago due to the right upper limb pain. That time it treated with painkillers, thinking as musculoskeletal pain, that resolved within 3 days. At that time, GP found a neck lump. As she is the GP working in the radiology unit, she arranged ultrasound scan and referred to our clinic for the further follow-up. There is a history in the patient's complaints of sleepiness, laziness, with the tiredness during last 6 months, with the poor school performance and the absentees. Patients having constipation with this recent weight gain. No recent change in voice or no neck pain or recent rapid enlargement we think about sinister signs, or fever, no weight loss, or no night sweats. She didn't have any shortness of breath or calf pain while exertion. She attained menarche at 12 years, but irregular cycles, but no menorrhagia. She had no bronchial asthma, allergic rhinitis, or skin rashes, or with joint pain. She didn't expose to the ionized radiation. She didn't on any long-term drugs. No drug or food allergies. Her development age appropriate in the no underwent any head and neck surgeries. The past history, sister is having thyroid enlargement and she's on thyroxine. In family history, her sister is having thyroid enlargement and she's on thyroxine. No any family history of the thyroid or hemolytic diseases. She is enjoying with her friends, no worries. She's in grade 10 with a poor school performance compared with the grade 9. So her teacher complained about that. Her mother worries about that. And in the family background, her elder sister works in the factory after A-level oral exam. And the younger brother is schooling. They don't have own house. So they are very poor. Parents are laborers and with a poor income. So even though his diet is adequate with iodide salt, inadequate with the nutrition, no fish, meat, or eggs. Other than that, not rich in the cabbage, manioc, or radish. This is the history. May increase sleepiness with the poor school performance during last 6 months. From the history, can you tell what do you think about the differential diagnosis from the history?
There are some background noises are coming. Kindly please to mute your phones.
The history mainly, can you tell me some differential diagnosis from the history?
Depression.
Yeah.
Hypothyroidism.
Good.
Any malignancies?
Which kind of malignancies? Yes, good. Yes, I also think first as hypothyroidism. Then the anemia, maybe the nutrition or the with the is increased blood loss with the irregular menstruation. And think about the hematological malignancies and some hemolytic disorders and the depression or some lymphoma. Then we look for the examinations. The height is 153. That is the no short stature, and the BMI within normal range. Her appearance is a good mood with a mild pallor, no ectory, no alopecia or no puffy face. She has had dry, coarse skin. No features of autoimmune disorders, some skin rashes or the vitiligo. No thyroid eye signs. On thyroid examination, diffusely enlarged thyroid gland, no nodules, none tender, no enlarged lymph nodes, no retrosternal extension, no growing. CVS and respiratory examination normal. In the abdomen, no hepatosplenomegaly. CNS examination normal other than slow relaxing ankle jerk. From the history and the examination, we can narrow down our differential diagnosis. Now, can you tell some differential diagnosis after narrow down the examination?
Hypothyroidism.
Yes. Hypothyroidism maybe the age is 15 years. Maybe the physiological or the acquired we can think at this stage. Or still we have to think about the anemia. Maybe iron deficiency or with the associated with the hypothyroidism. This is the investigations. We order for first full blood count. I put in change first full blood count. The hemoglobin level 11.2 with the PCV 36, MCV 78, reduce, ESR 12. Then we did the TSH. TSH patient's value is 8.45. It's some high than the normal values. So we arrange pre-T4. It's also 10.25, small amount reduced than the reference values. She's already having thyroid ultrasound neck, thyroid scan of the ultrasound scan of the thyroid. That diffusely enlarged thyroid gland suggestive of thyroiditis, no thyroid nodules or lymph node enlargements. So because of after looking at these investigations, we arrange a lipid profile and to identify the cause for the hemoglobin, reduced hemoglobin, we arrange blood picture and the serum ferritin. So we diagnose it as a hypothyroidism, most probably with the Hashimoto's thyroiditis with the iron deficiency. So counseling and then with the mother and the child, we counsel. Then we manage non-pharmacologically dietary advices and the pharmacologically, we start thyroxine 25 micrograms daily and the advice given for the compliance and the importance of the take long-term treatment and the morning with that we have to take it empty stomach and this advice is given. So follow-up plan, repeat TSH in the 6 month, iron therapy after blood picture and serum ferritin reports, and septinatin about the feeling of the palpitation of the chest pain, need to consult a doctor. Symptoms of or the patients having symptoms of thyrotoxicosis, need to assess TSH early. This is the summary of the my clinical presentation of that patients. With that, we look for some details about the thyroid hypothyroidism. This is I put this to memorize some anatomy of the thyroid gland. The regulation of the thyroid hormone secretions is hypothalamus. Thyrotropin hormone release that act on the anterior pituitary release TSH, thyroid stimulating hormone. That act on the thyroid gland and release thyroxine T4 and the T3 that act on the target tissues. Thyroid disorders mainly hypo and hypothyroidism, as we all know. We mainly talk about the hypothyroidism here. In the primary hypothyroidism, failure of the gland, under secretion of the free T4, 95% of the cases. Secondary hypothyroidism, pituitary problems, congenital hypopituitarism, or pituitary necrosis, Sheehan's. Tertiary due to hypothalamic dysfunction. Other than that, peripheral resistance to the thyroxine hormone also present as the hypothyroidism. In the congenital, when the primary hypothyroidism, congenital may be thyroid agenesis, dysgenesis, or defect in PT4 synthesis. Acquired autoimmune is the most common cause for the acquired hypothyroidism. Atrophic hypothyroidism or autoimmune Hashimoto's thyroiditis, the most common type. Other ones are defect in hormone synthesis. Some drugs, amiodarone or lithium, interferon, interfere with the synthesis of the thyroid hormone. And the iodine deficiency and the antithyroid drugs reduce the synthesis of the hormone. Then the iatrogenic radioactive iodine or thyroidectomy radiotherapy and head and neck tumors. And the infiltrative sarcoidosis, some tumors, amyloidosis, scleroderma, hemochromatosis, that can cause infiltrative to reduce capacity of the production of the thyroxine. And some idiopathic or subsequent to the Graves' disease. When treatment given for the hyperthyroidism, subsequently gland atrophy and develop hypothyroidism. When we look for some prevalence, iron deficiency, iron insufficiency areas, what hypothyroidism 1 to 2%. Female 10 times higher than the male. Worldwide annual incidence of Hashimoto thyroiditis is also 1.3 to 1.5 per 1,000 persons. In the lifetime prevalence, female 9% and the 1% in the male. Normally, age diagnosed around 60% mean age. During the pregnancy, 0.5% overt hypothyroidism, 3.5 subclinical hypothyroidism. Congenital hypothyroidism, 1 in 3,500 births. In the Sri Lanka, Universal Soil Iodinization program started in 1995. After that, the commonest cause for hypothyroidism is the Hashimoto's thyroiditis. We look for some clinical features hypothyroidism, mainly due to the decreased metabolic rate due to lack of thyroid hormone and the increased matrix protein accumulation, the commonest causes for the some clinical features. Reduced metabolic rate, fatigability, weakness, cognitive dysfunction, short stature, bradycardia, slow relaxing ankylate, like that. And matrix protein accumulation caused periorbital edema, puffy face and loss of eyebrows, hoarse voice, dry skin, and macroglosia. Other than that, other mechanisms increase the fluid retention, pleural and pericardial effusion, ascites, menorrhagia, depression, galacturia, and diastolic hypertension is common. In the special situations, we have to look for the, we have to investigate for the hypothyroidism. These are the causes. Personal risk factors in the patient with the strong family history of hypothyroidism, newborn mother with the thyroid diseases, past history of neck irradiations, patients on drugs, lithium and amiodarone, patient with other autoimmune disorders, we have to investigate for the hypothyroidism. And a patient with the goiter or associated with the syndrome, Down's Turner's, and the abnormal biochemistry, the sustained hyperlipidemia, unexplained hyponatremia, high serum creatine kinase, macrocytic anemia. I will explain how this happened in the later slides. Associated clinical conditions, some pericardial and pleural effusions, pituitary hypothalamic disorders. For the cause, we have to look for the hypothyroidism. And most of the hypothyroidism associated with the autoimmune diseases, like vitiligo, Addison's, and common autoimmune disorders. If patient present with this, we have to investigate for the hypothyroidism also. Other associated, this I already discussed here. And in the hypothyroid investigations, as we done for our patient, the investigation is the TSH. If it's abnormal, we have to do the TT4. Thyroid ultrasound we assess for the size and the echo texture of the thyroid, whether it is diffuse or nodular, and then for diagnosis and evaluate of the patient's thyroid nodule. That's important for the ultrasound scan. If we are suspecting the nodule or we want to diagnose the histological type, we can arrange the FNAC, but should arrange ultrasound guided FNA because we have to select the dominant or suspicious nodule. To assess the etiology, we can arrange the thyroid autoantibody test, even though it's expensive. In the hypothyroidism, thyroid peroxidase antibody TPO and the thyroglobulin antibody, anti-thyroglobulin antibody. That's increase in the hypothyroidism. Then the continuation of the other investigation to assess the complications for the special situations. In the complete blood count, full blood count, there's anemia. Anemia may be associated with 30 to 40% of the patients with hypothyroidism associated with anemia. So anemia may be due to reduced erythropoietin level, or the iron deficiency may be associated with iron deficiency if microcytic hypochromic iron deficiency, or sometimes normochromic normocytic, or macrocytic anemia may be associated with the pernicious anemia or vitamin B12 folate deficiency. So if the blood count and blood picture suspecting about that, we have to investigate further. And we ESR with associated with autoimmune and any other conditions, and the serum electrolyte is the hyponatremia. Hyponatremia due to the increased water clearance, reduced water clearance with the hypothyroidism. Other than that, increased ADH secretions in the patient with the hypothyroidism. So, hyponatremia, in the isolated hyponatremia patient, we have to look for the hypothyroidism. The most common presentation is the abnormal lipid profile. That may be that due to the in the lipid metabolism and the lipid breakdown and the removal of the lipid need thyroxine hormone. With the reduced thyroxine, the accumulation of the lipid, mainly total cholesterol, triglycerides, and the LDL. So when patients with the elevated lipid profile, we look for the features of the hypothyroidism and investigate for that. With the treatment of the thyroxine, we can wait, the lipid level may be reduced without lipid lowering drugs. And the creatine kinase may be the muscle breakdown and the myalgia and the myositis. Other one is the serum prolactin level. In the hypothyroid patients, serum prolactin level increase. Prolactin level increase may be due to the increased TSH and the reduced thyroxine stimulate the thyrotropin hormone. At that time, lactotropin also stimulation from the lactotropin. Lactotropin increase the prolactin secretions. With the other one is the reduced removal of the prolactin. These both of those increase the prolactin level. Increased prolactin inhibit gonadotropin secretions, FSH-LH. That's why a patient with the hypothyroidism, anorexia cycle with menstruation with menstrual abnormalities, and the galacturia and the infertility common with because of the hyperlactin levels. Other than if the suspect is small pleural effusion can be due to the increased fluid retention, ECG changes can happen in the echo pericardial effusions. When we evaluate the suspected hypothyroidism and the when first line is a TSH, when the TSH is elevated, patient we have to do the pre-T4 levels. Pre-T4 levels normal in the subclinical hypothyroidism. TSH high, subclinical pre-T4 normal. If pre-T4 low, the primary hypothyroidism, they need thyroxine treatment. When the TSH normal or low, we suspecting about pituitary disease. Yes, measure pre-T4 low, evaluate anterior pituitary function. Normal or low TSH with the low free T4 level, anterior pituitary function assess. And if normal, no further free T4 normal, no further test. This is a summary. If TSH high, free T4 low, primary hypothyroidism. TSH mildly high, up to 10, 4 to 10, and the free T4 normal, subclinical hypothyroidism. TSH normal low, free T4 low. Central hypothyroidism, look for the central causes. Then when we talk about the ultrasound thyroid, we mainly done for the evaluate the thyroid goiter if present, and they look for the nodulity at the diffuse enlargement. If nodule present, determine TIRAD score for the risk classification. TIRADs mean thyroid imaging reporting and data system. A scoring for stratified risk of malignancy based on ultrasound appearance. To identify the malignancy, I put this because of most of the ultrasound reports come with the TIRAD classification. So we have to know whether the patient need FNAC or not. So I just put this slide. If they are 2 point, here the according to the echogenicity shape margins, they put marks, and the here TIRAD 2, 1, 2, 3, 4. Most of the mild suspicious with if more than 2.5, we have to arrange the FNAC. If the no suspicious, no FNA in the TIRAD 2. In TIRAD 3, we have to think about the mild suspicious. So if the 2.5 centimeter more than 2.5, we have to send for the ultrasound guided FNAC. So we think as this, and we should memorize this slide, and whether the report is coming, we are in the further follow-up of the patient. The ultrasound guided FNAC and the histology. FNAC of suspicious cold nodule, dominant nodule to exclude malignancy. Most of the suspicious nodules are cold nodules, and the texture, the vascular or the micro classifications, we look for the suspicious nodules. On the fast growing goiter, to exclude a thyroid lymphoma. And to identify the type of goiter, we have to do the FNA. See, but the management of the thyroiditis, we don't need the ultrasound guided FNAC. In Hashimoto's thyroiditis, the histological diagnosis. Gland shows diffusely lymphocytic and plasma cell infiltration with the atrophic thyroid parenchyma. If we need definitive diagnosis, we can arrange ultrasound guided FNAC. Then here we no need to ultrasound guided. We can arrange the FNAC for the histology. Then some thing about the thyroid antibodies. Hashimoto thyroid, in the Hashimoto's thyroiditis, the destructive antibodies. There are two types of antibody positive in this Hashimoto's thyroiditis. Thyroid peroxidase antibodies, TPO antibody, and the antithyroglobulin antibody. In the 90% of patients positive with the thyroid peroxidase antibodies, but 10% negative. With the treatment, no change in the antibody. If the patient is euthyroid, but antibodies still present. Antithyroglobulin antibody we can use for the tumor as a tumor marker for the thyroid cancer as well. In the presence of the thyroid peroxidase antibody in the subclinical state of the hypothyroidism, the patient may be going into the definitely go into the hypothyroidism in the future. In the Graves' disease, TSH receptor antibody is positive. And we usually don't go do the thyroid antibodies, but we can we can confirm the diagnosis by doing thyroid antibodies. When the management, levothyroxine is the thyroxine replacement, dose can range from the 50 to 200 micrograms per day. We can calculate the dose by the 1.6 to 1.8 microgram per kilogram per day is the for the actual body, and we calculate according to that nearest 25 microgram. 25 to 50 microgram per day in the mild degree of hypothyroidism. In our patients, we start 25 micrograms as the TSH level less than 10. So, at the subclinical hypothyroidism, if TSH less than 10 or subclinical hypothyroidism, we start low doses. The initiation of the thyroxine, patient with the less than 50 years, we can replace full dose. If the patient more than 50 with the cardiac disease, we have to do ECG monitor before this starting. Then start a dose 25 to 50 micrograms and started the dose with a check-in TSH level 6 to 8 weeks with still TSH normalized. If the patient is symptomatic, we can arrange the ECG and the monitoring with the monitoring. Even in the patient with a cardiac disease, if we difficult to keep the patient in the normal range of TSH level, the near normal level is acceptable because we can't increase the thyroxine dose because of the heart disease. The special precautions and the advices we have to give for the patients while taking thyroxine. We have to take it to the empty stomach because thyroxine absorption is increased with the empty stomach. Spaced out the meal, tea, coffee, at least 30 to 1 hour duration. Other potentially interfering medications and supplements by 4 hours, such as ferrous sulfate, calcium, aluminum hydroxide, like antacids. When we prescribing for the pregnant women, they are mostly taken the vitamins, so we should advise correctly. This should take 4 hours after the thyroxine supplement. Thyroxine should store 25 centigrade below the 25 and protect from the light. So we should keep in the brown color bottles and protect from the moisture. If the patient need the indications for the surgery, the large goiter with obstructive symptoms or cosmetic reasons or the presence of malignant nodule lymphoma is the indications for the surgery. When we're treating, if suspecting central hypothyroidism, it's mandatory to evaluate the anterior pituitary hormones before replacing the thyroxine, because if any cortisol deficiency, if you replace with the thyroxine, that will end up with the metabolic trigger the steroid crisis. So to prevent that, we have to look for the central causes, and the you have to look for the other hormones, pituitary hormones levels. How do you follow up the patient with the patient on thyroxine? The symptomatic improvement is expect within 2 weeks. The optimal treatment within thyroxine will normalize the TSH level. So when the patient, we start the thyroxine, we should check the TSH level 6 to 8 weeks until the desired level achieved. When the patient is euthyroid, then we can review the 6 to 12 month interval TSH level we can monitor. When the dose or type of the thyroid preparations change, we should again repeat the TSH level in the 6 to 8 weekly until desired level achieved. The routine clinic visit, we should look for the physical examination, the weight measurements, pulse and blood pressure, and the thyroid examination for the presence of thyroid nodules. And the clinical evaluation for the symptoms of hypothyroidism or iatrogenic hyperthyroidism. We should ask for the symptoms of the hyperthyroidism as well. The patient should monitor the symptoms and signs or treatment such as tachycardia, palpitation, tiredness, increased excitability, and the tremor, and the possible angina also. The adverse effect of the over-treatment is mainly increased risk of osteoporosis and the atrial fibrillation. The adverse effect of under-treatment in the hypothyroidism, and the dyslipidemia, and progression of atherosclerotic cardiovascular diseases, and progression of congestive heart failure and cardiomyopathy. And while treating the patient, we have looked for the compliance and the causes for the failure to not normalize the TSH during the treatment. Most of the time, we look for the compliance or the factor affecting the absorption. We should give the proper advice. How do you take the thyroxine, or whether look for the patients taking correctly, whether they're taking close to the meal or during interfering with the absorption. Sorry, some drugs interfere with the absorption. Some cholestyramine, parasulfate I already mentioned. So we have to keep the 4-hour gap in between thyroxine and the dead drugs. Other causes, we have to look for the other causes of the malabsorptions. Sometimes patients have low thyroxine with the low hemoglobin, albumin. We have to look for the malabsorption syndromes like lactose intolerance, celiac disease, so H. pylori eradications, and some drug accelerating the metabolism, phenytoin, carbamazepine, and rifampicin. And there's some bioavailability of the different levothyroxine preparations may differ. So if the patient comes with the failure of the normalized TSH, we have to look for those things. Then I discuss some special occasions of the hypothyroidism and the subclinical hypothyroidism. And the worldwide prevalence is the 1 to 10%. Mild increased TSH level less than 10. Normal free T3 and T4 levels, but pre-T4 level is normal. At that time, we consider treatment when patient symptoms of hypothyroidism, or patients having goiter, or the positive anti-thyroid peroxidase antibodies, or patients subfertile or planning a pregnancy, abnormal lipids, or atherosclerotic cardiovascular diseases, heart failure, associated risk factors for these diseases. At that time, treatment started for the subclinical hypothyroidism. And the special situation, hypothyroidism in the pregnancy. Untreated hypothyroidism increase maternal and the fetal complications and fetal cognitive development. So, screening of pregnant women if symptomatic or family history of hypothyroidism. If we identify the patient with hypothyroidism, we have to refer for the specialist care. Patient with overt or subclinical hypothyroidism, levothyroxine replacement, and the TSH within trimester specific range, we have to keep the TSH within the trimester specific range. There's the specific levels for the trimesters, which is lower than the normal values of the TSH. In the first trimester, we have to keep the 0.1 to 2.5. In the second trimester, 0.2 to 3. In the third trimester, 0.3 to 3.5. In the first trimester, sometimes TSH may be low due to the dilutional effect. But we have to keep the TSH level within these ranges. In the increased thyroxine dose by 30% as soon as pregnancy confirmed. If the patient is the hypothyroidism, getting pregnant, we have to increase the thyroxine dose by 30%. Further change based on the TSH level, if because of the increased requirement. In the here, usually we did the 6 to 8 weekly in the TSH measurements. But here we have to measure every 4 weeks until TSH become normal for the trimester level. Postpartum thyroxine level reduce up to pre-pregnant level after the 4 to 6 weeks by doing TSH. Screening of newborn with the TSH is recommended, but in our country all the newborns are screened for the hypothyroidism. Here I put some with increased requirement because of pregnancy. The adverse maternal fetal complications due to hypothyroidism, untreated hypothyroidism can cause fetal miscarriages, preterm birth, low birth weight, and the impaired neurocognitive development. That is the bad thing. In the maternal gestational hypertension, preeclampsia, and the increased risk of placental abruption due to the untreated hypothyroidism. In the postpartum thyroiditis, presence of thyroid TPO antibodies during first trimester predict the development of postpartum thyroiditis. Repeat TSH within 3 to 6 months postpartum. We have to repeat the TSH 3 to 6 months after postpartum. Risk of developing permanent hypothyroidism is high in patients who have a postpartum thyroiditis. Annual TSH level should be performed in these women. So we have to annually screen for the TSH hypothyroidism. Treatment with the levothyroxine if TSH more than 10. TSH more than 2.5 in women plan to pregnant near future. When we doing TSH levels, if patients having more than 2.5, we have to start the thyroxine if plan to pregnant near future. That's the value of the first trimester value. It's the 0.1 to 2.5. Women with postpartum depression should be screened for the hypothyroidism. The most important is the congenital hypothyroidism. We have to identify early and treat earlier as possible to prevent the permanent neurological damage. It's common in the 1 in 3,500 births, causes permanent neurological and intellectual damage with the stunted growth, cretinism. short stature, hearing and speech defects. So routine screening done of the all newborn babies in the Sri Lanka. If we identify the defect in the thyroxine hormone, we have to start as early as possible the thyroxine treatment, and we have to refer for the specialist endocrinologist. Investigations at the TSH for ultrasound scan of the thyroid. We have to arrange ultrasound thyroid also, and the refer for special center for the treatment and follow-up. Starting dose of the levothyroxine in neonate 10 to 15 micrograms kilograms per day. With the follow-up, that's also different from the adult population. TSH pre-T4 test more frequently in the 2 to 4 weeks after the initial treatment until pre-T4 normalize. 1 to 2 months after the first 6 months. Sorry, during the first 6 months, we have to done the TSH for the 1 to 2 monthly in the 1 to 2 month interval. Then every 3 to 4 months between 6 months to 3 years. Then every 6 to 12 months. After normalizing, we have to repeat until normalize. We have to do it 2 to 4 weeks until normalize. After normalizing, until 6 months, 1 to 2 months, and 6 months to 3 years, 3 to 4 monthly, then 6 to 12 months. After 3 years, 6 to 12 months. Keep pre-T4 in the upper half of the normal range. Keep TSH T4 in the upper half of the normal range. TSH within the reference range. Growth monitoring and the development assessment. Because of the high prevalence of the hypothyroidism, the age of the group and symptoms may be subtle, including hoarse voice, deafness, dementia, confusion, depression, ataxia. The patients in the old age can present as dementia, confusion, depression. So, upper limit of the normal range of the TSH increase progressively with the age. In patient between 70 to 80 years, reasonable to keep TSH targets and the use of small starting dose 25 micrograms or 0.4 to 0.5 micrograms a kilogram. Because of our patient is suspecting the Hashimoto's thyroiditis. More details about the Hashimoto's thyroiditis. Commonest autoimmune thyroiditis, common women 6 to 1 and late middle age, present in the 30 to 50 years of the age. In the familial, 9-fold risk of first degree relatives. Ectropic changes with regeneration, goiter formation, thyroid autoantibodies present, associated with the other autoimmune conditions, usually hypothyroid. Levothyroxine may shrink the goiter. There is an increased risk of papillary and carcinoma and lymphoma. In the talking about our case in the patient is a 15-year-old. The adolescent and teenagers most common cause of acquired hypothyroidism, Hashimoto's thyroiditis. 1 to 2% of the teenagers, 50% familial. High risk of associated with the autoimmune conditions. Teenage common presentation with the not show classic features, poor growth, delayed puberty or arrested puberty, irregular periods. Young women, amenorrhea, menorrhagia or infertility or prolactin. With the new treatment other than thyroxine, they have done some research levels, but for all the thyroxine is superior than all the treatment. Immunotherapy, they have started the biological drugs, rituximab and the tocilizumab, suppress the overactive immune response, improve the thyroid function and reduce antithyroid antibody. And thyroid hormone analogs like tiratricol, and thyroxine peroxidase inhibitors to limit the autoimmune attack, and selenium supplements. I think selenium is important for the metabolism of the thyroid hormone. So selenium supplement increase the production of the thyroxine. And the vitamin D supplements improve the thyroid function and reduce the antibody level. Between patient with the vitamin D deficiency with the high risk of the hypothyroidism, they have identified that. And the mesenchymal stem cell therapy modulate immune system, regenerate damaged tissue. This is some new drugs, but most of under the trial level. In the complete, the untreated hypothyroidism, the thyroid emergence is the myxedema coma. Severe hypothyroidism, especially in the elderly, present with confusion of coma. And the severe cardiac failure, pericardial effusion, hypoventilation, hypoglycemia, and hyponatremia. So treatment with the warm humidified oxygen, if need, ventilate, or monitoring of cardiac output and the pressure and the other vital parameters, gradual rewarming, and the hydrocortisone 100 milligram 8 hourly, and the glucose infusion, and the IV thyroxine if available. We can give, otherwise in the levothyroxine 300 to 500 in the loading dose with the NGTO. Then maintain dose we have to maintain. Myxedema madness is the depression associated with the hypothyroidism. That also can present it's as the in untreated hypothyroidism. Then we can you remember what happened in our patient? She is clinically hypothyroid, and the examination diffuse thyroid enlargement, investigations, and TSH less than 10. That means subclinical hypothyroidism. But in the pre-T4, less than the normal range. So not subclinical. She is hypothyroidism. Is ultrasound is a thyroiditis, so is maybe hypothyroidism due to the thyroiditis. Hypothyroidism in the here teenage, and the most common thyroiditis is Hashimoto, so we think it's a Hashimoto's thyroiditis. So may manage as a Hashimoto's thyroiditis. As a reference from the Thyroid Disease Sri Lankan College of Endocrinologists Clinical Guidelines 2015. That's the newest guideline for the national guideline thyroid diseases, and from the medicine and the radiopedia and the command clerk. That's the end of my presentation. Thank you very much, Madam Malkanthi Galhena, for support and always help me to prepare this presentation. And thank you all the colleagues. If you have any questions, now you can ask from.
Okay, thank you, Suvimali. Thank you very much. It's, regarding your presentation, this is the real clinical scenario patient that I can assure you all. So the real learning points that you can learn a lot, right? For the patient-centered management in the first contact care, right? And as well as, Suvimali has provided a lot of, the knowledge about for you all to refresh, to analyze the symptoms as well as the coordinated the symptoms and signs into the pathology and the physiology. So it's from my perspective, it's real, the very good presentation. And because I'm well aware about the patient, so I can say that she has done a good job. And as well as, we can, the others also can learn, the update your knowledge according to the guideline based management, which is very important in the management of patients in first contact care. So the most important thing, in this patient, the importance of the history taking, I'm always telling you, according to the report, even though this patient has come with a report, right? So you have to, the once you go through the report, you can identify what the problem that the patient has. So here the ultrasound scan report saying thyroiditis, enlargement of the thyroid gland, and it's a thyroiditis. So then even though at your practice or at your exams, right? So even though the patient brings it, you again do, the same, the clinical, the evaluation of the patient. That is, the establishment of the doctor-patient relationship, then the proper history taking, including analysis of the symptoms, main symptom for the presenting complaint and the duration, and then the age of the patient, then decide about your possible differential diagnosis with the support of analysis of presenting complaint without, the skipping to other past medical history and all. Then go to exclusion of possible red flag symptoms in case here it's, the malignancy associated with the weight loss and other things. And then you have to go for the, the psychological and the social history of the patient, past medical history, psychological and social history, family history, and the behavioral habits. You have to, right? That is called use your 3D approach or holistic approach of data gathering. That is a must, right? Because sometimes you might find some, the factors among social and psychological history. And one boy, the suggested when Suvimali asked for the differential diagnosis, he suggested that's a depression. It's very good, the way of thinking, because these similar symptoms may be coming with the patient of without any other diseases, but due to, the moderate to, some sort of moderate to severe depression. So that's a real good thinking. So always think about possible red flag exclusion from the history taking. So history taking in the correct approach with 3D, that it's holistic approach, that gives you correct, the information for you all to come to your differential diagnosis, to minimize your differential diagnosis that you have at the beginning, to come to the, the most possible, the clinical diagnosis, right? Tentative clinical diagnosis, which needs to be confirmed by the examination. So that examination, you need to have your examination skills. So if you don't have, the examination skills to how to palpate the thyroid gland, you're going to miss this patient, right? So your diagnosis may not be, the confirmed by the clinical signs where you have found for the, you have narrowed down your tentative possible clinical diagnosis. So your clinical examination skills is a must. Now itself, I can say that you all will not practice that. And even my trainees didn't, have that skill, but I hope that I have, the emphasize the importance of it. And I have, the trained them to some extent, even though repeatedly telling, still they used to do the mistake. But this is the reflective learning. So you should not forget about that. Examination of the thyroid gland, examination of the pulse rate, and as well as the ankle jerk. The relaxation, slow ankle jerk relaxation is very important things in, in the case of coming to the diagnosis of your clinical tentative diagnosis of hypothyroidism you found from the history. So if you don't have that skill, you are going to miss it. Okay. So your clinical, that is your whole ambition is to narrow down your investigations to the minimum possible investigations in order to confirm your clinical diagnosis. So because of that, you need to have your establishment of good doctor-patient relationship. Again, the holistic approach in data gathering, and as not unwanted in this, you all are spending a lot of time with, the asking so many questions unwantedly, that shows that you are not competent enough in history taking, but you have to have your own practice to narrow down with the correct information and the exclusion of red flags and psychosocial history. So other than that, your exam also, you are wasting your time more than expected in the history taking, and then your examination and the management will not be have enough time to complete your the case scenario. So because of that, keep that in mind, your knowledge about, the diseases, that is to trace the evidence-based information, you have to have your knowledge. So knowledge about this is which Suvimali provided us superb knowledge about, the hypothyroidism from her. She has done a, the great job with, the spending lot of time for you all to give this knowledge. So please take this knowledge and, expand your knowledge further. Then the next important thing is, in this case, this is the patient-centered, always we are doing patient-centered management. So we are going to find out why this patient got hypothyroidism, and as well as why this patient got anemia, right? So she explained very well the anemia, right? Any type of anemia could be associated with, the hypothyroidism due to low metabolic, the compensation. So that this patient has, microcytic hypochromic anemia with iron deficiency confirmed by the blood picture and serum ferritin level. So now, and on top of that, she has found very well she detected the dietary inefficiency, not enough inadequacy due to poor psychosocial status of these people, right? So because of that, so it's the problem is, the clinical diagnosis is hypothyroidism, which is confirmed by the examination, and as well as the anemia, which is may be associated with, the hypothyroidism and the dietary deficiency, right? So in her management, before come to the management, counseling need to be done. So the counseling is here, right? It needs to be very correctly mentioned to the patient what is this disease that she has. That is the important thing, that before you come to the management, counseling is not the talking about management. Counseling is you have to give them the clear instruction, clear information, so that she will understand what this disease is, right? That is that. So in this case, you have to tell that to the patient, this is, your low production of your hormones due to some inflammation is going on within your thyroid gland, neck gland called thyroid gland, right? So with that, the work has been, the work has been delayed. So which, the cost for the iron deficiency as well as the less poor performances, right? So clinically, it looks like hypothyroidism with the investigation report, right? So what you are bringing to us. So, and the problem is, associated problem is not only the low thyroid gland function, but associated dietary deficiency in, the imbalanced diet that you all are taking, that you have to tell. Okay, and the period irregularity also may be a cause. So aggravating due to the disease that patient is getting, we don't know, by no menorrhagia according to that. So it's unlikely. Anyway, irregular periods can cause, if it's coming frequency, to the blood loss as well. So in management, so counseling is that there are 3 causes for you to have this, the lethargy and these things. One is hypothyroidism. The second thing is hypothyroidism associated with iron deficiency, and number 3 is, the dietary deficiency and the period irregularity, which is the part of the disease. So you have to tell them in the management. First thing is reassurance, right? You have to tell the parent everything is based on this malfunction of the thyroid gland, and its inflammation has been started, where you need to know that is management, not counseling, where you need to attend regularly to the clinic, and in at least 6 months or once a year, we need to just check the thyroid gland, the scan as well, and the TPO antibody levels, to assess the progress of this, the inflammation which causes thyroiditis. That is very important. Otherwise, if you start this and forget about that, patient might stop it. Patient may continue the same dose, right? Which is it's not a good thing. If you give that, the advisors in management, you to attend regularly to this clinic and according to the medical instruction, and to remind the doctors wherever she goes to check with her thyroid function, TPO antibodies, and the ultrasound scan of the thyroid gland in order to detect the severity of the thyroiditis. It is Hashimoto's commonly, as Suvimali mentioned. So it will be progressed to the severe the thyroid deficiency. So because of that, it's very important to be follow up. Ideally, that is the baseline, evidence-based management. You need to talk about the evidence-based management at the exam especially. And that is good for the patients as well in case that patient can afford. Or if there are some, the tests are available, then you can refer to that particular, the unit for them to get these tests done and come back. Okay. So here, that what we have done is even though the Suvimali's management is, the sort of okay, but I feel that it's not patient-centered, right? The patient-centeredness is always, I'm telling, because we have to find what the exact possible cause for her complaint and what is what are the reasons for that from the history, and confirm the diagnosis from the clinical examination with your skill, and then do the counseling and come to the management to address those, the underlying possible causes, right? She has, the advised the patient about taking thyroxine as well as, the going for the follow-ups. And then, she has not mentioned particularly, not given the knowledge about the progressiveness of the disease and the importance of coming to the clinic and the, the continuation of the scans at the TPO antibody levels. Okay, so that is not there. And dietary, the factors has not been addressed at the, is that so? So Himali, am I correct? Dietary factors in the sense, not the thyroid, the thyroxine lowering dietary factors, but to enhance the iron deficiency, you didn't know, although you have prescribed ferrous sulfate, you never addressed that, no?
Yes, madam.
Okay, so that is the main, the error in your management. That is not patient-centered then. So another cause is the irregularity. Irregular periods in the sense will be all right with correction of the thyroid disease, because the metabolism, and you talked about, the how it affects the hormonal deficiency. So with that, she may be all right, but in case that irregularity, after 3 months time the continues, we need to get the proper it's better to get the VOG's advice as well, because we don't know, this may be solely due to the hypothyroidism, right? So if it's get corrected, the improvement of clinical symptoms, that's okay, right? So those are the 3 things you need to address. The found causes need to be addressed at the management. That is called the patient-centered management. And the other thing is you negotiate always not to order, to do this and that. Is it possible for you to, through negotiations, you are going to do the management. So I hope that she has done a good job, except in the management, right? So this is the real case scenario, and I have seen how, the patient, how the empathetic, the Suvimali to the patient, and as well as, how skillful to detect, the symptoms and the signs, as well as, the come to the correct narrow down investigations without, the and other important thing is always keep that in mind. Go with lipid profile. Once you see, the normal thyroid function report. So you have to, think about doing the lipid profile, because this is the comorbidity dyslipidemia due to this one. So in such a case, you have to think about starting the atorvastatin as well without calculating the CVD risk as well, right? So, moderate dose of statins can be started. And other important thing is, this is, she was talking about, the subclinical hypothyroidism, right? But if the patient is having, this is mild, or the elevation of the TSH with mild elevation of FT4, but patient is having full-blown symptoms. So in such case, we can't say that it's subclinical because patient is having symptoms. Because of no clinical symptoms, only we are telling subclinical. Such patients need to be, the investigated in case that patient doesn't have that clinical report, clinical symptoms, need to be investigated correctly at 6 months interval in order to detect whether she is going to get progressive, the hypothyroidism. That is the importance of subclinical hypothyroidism. And if any other risk factors like dyslipidemia and any, the family history of MI, or any possibility among the patient that patient is having diabetes or this thing, more prone to get CVD, then we can manage by giving the tailor-made dose according to the other other comorbidities that patient is having. So other than that, subclinical hypothyroidism mostly may not need the treatment, but may need to, the go ahead with, the monitoring of the symptoms as well as the biochemistry and the scan. That's very important to keep that in mind. You may get in the similar case like this thing in exams, that is common. The patient may be coming with subclinical hypothyroidism or may be coming with full blown. But keep that in mind. Always you have to take, a holistic approach in history taking and come to the exclude red flags, disease, possible symptoms, and do your clinical examination with understanding to confirm, the clinical signs. Then come to the clinical diagnosis confirmation, then, the counseling about the patient's disease, and then start the management with reassurance and, the non-pharmacological and then pharmacological management investigation, reassurance and investigation, very important. Then cost-effective investigation only, because cost-effective in the sense essential, right? Even though it's costly for this patient, TPO antibodies is a must, because young patient at this time, if we miss her, we don't know whether she will get, the rapid, progression of the disease, which we need to understand and keep eye on her, prevent going into this thing. And the management, investigation, reassurance, investigation, then pharmacological management, thyroxine according to the body weight, and then, the go ahead with the subsequent problems assessment, management, that is the dietary deficiency, iron deficiency, and as well as, the school performance. Reassurance on school performance should be done for this patient. We can't just reassurance, that is the patient-centered management again. So mother need to be, the reassured child need to be reassured her school performance will be back with this. That is very important. And the supportive management need to be done by the mother with, the enhancing the dietary factors within the affordable way, right? And the follow-ups, and then referral in case if we can't pay, this patient can't afford. So because of that, we may need to, send this patient to the NHSL endocrinology, because TPO antibodies, which we can't, it's not available here. Or there are some labs like medical faculty, they will do for the reasonable cost, but it's a must for them to do this test for this particular patient. So you can arrange after having negotiation, right? Sometimes they may say uncle or someone in the family may be, they're able to afford. So like that, and the correct knowledge, after going through the thyroid function report, whether this is a primary hypothyroidism or secondary hypothyroidism. She gave you the correct way of diagnosing. And in case if it's a primary, how to manage. And in case we know the secondary, how to manage. and other, the symptoms in pathological way she explained very nicely. I appreciate well, like galactorrhea and, the iron deficiency and those things, right? You have comprehensive knowledge about the disease and how it happens, but you have to build up the art of getting the correct history in a format that I told, and, find out the causes for this current issue, and then confirm the diagnosis by improve yourself for the clinical skills, and then improve your counseling skills. I know that it's not there with you, because when I got trainees, I knew that it's the very, the deficient, the skill that you are having, and then go for the management. Also, management should be according to the best evidence-based management to address the patient's issue, not only the book's issues, right? These patient's issues, this is hypothyroidism and underlying possible causes and relevant other factors need to be, because school performance is the main thing. If you don't address that, you are not going to be a patient-centered doctor, right? So that is very, very important, because patient came with, once you listen to the report, the patient has gone to the doctor because of the poor school performance. So because of that, you need to address that. Okay. So that is very important thing. So I think she has done a very good job. Any other questions, if you have, now you can come up. And this is your time, you can discuss.
Thank you very much, madam, for your
Yeah, thank you,
clarifications
Suvimali.
taken.
Right. It's a wonderful presentation. Thank you so much. You have to identify your gaps and improve.
Yeah, ma'am. Thank you. One question, madam.
Yeah.
Don't we have to arrange for FNA for the adolescents identify Hashimoto thyroiditis?
No, definitely. Because, the FNAC is mostly, because thyroiditis can be detected from ultrasound scan, right? Mostly. But in case of FNAC is really indicated not to confirm the diagnosis of the thyroiditis, it's to identify whether it's a cold nodule or hot nodule, right? So in case of ultrasound shows that it's nodules, from nodules they may take the FNAC. That is the main, the aim, focus to detect whether this is malignant tumor or not. Okay. So because of that, in such case, for mostly the patients who are having the nodular goiters are the one need to be sent to the FNACs, not thyroiditis patients.
Okay, thank you, madam.
Thyroiditis is need to be going to monitored through the TPO antibodies. Any other questions? And she gave you the correct, this gradings, thyroid, this thing. Grading, TIRAD grading. That is also very important thing, because reports comes as that. Then you must know, because all other disciplines, when they are there. So first contact, if you are very much knowledgeable, that is what other countries they have done. So whenever we got our training in UK, we are being, given the real good knowledge at the side of the computer. Whenever you want to check it, the computer, once you press the button, each and every knowledge will come, right? So because of the availability of knowledge, guideline knowledge, and the research knowledge is very important. It's a summary. So it should be on the side. So, but you can't say that we are not aware of that, because whenever you are going to, refer the patient to the endocrinologist, or hypothyroidism, we can manage. No need to send to the endocrinologist always. But if it's the deficient in case of, the hormone assessment and these things, you have to enzyme at thyroid peroxidase, the antibody levels. Then you have to refer for that purpose only. Other than that, we can manage. Okay. So because of the dyslipidemia, it's very important, correlated, the comorbidity. Always you have to assess about that and start the treatment in case if needs. එතකොට ඒ වගේ we have to have knowledge make grading එක දැක්ක ගමන්, so you have to be able to identify what this grade is and what are the what does they mean by that. So it equals your the knowledge with others consultants. You are not far behind. You have to have your in-breadth knowledge. So because of that, if you know that, so the in-depth knowledge to some extent, that is really great, right? Because we can, the coordinate with these consultants in order to provide a better management to our patient. So you have to know these things. You don't think that these are not necessary. In-depth knowledge also very much important, particularly in a country like Sri Lanka, where the other consultants are going, especially letting down us, saying that we have to be, the base to the very small, the peripheral units or divisional hospitals. There are no facilities to be detected for the patient management. That is not in standard with the other countries. Other countries, where we got our training is, in par with other standards with the secondary and tertiary, because we have to have this knowledge, but we have to send them for the other levels for particular care that they have been trained, right? So because of that, we need to send them only for that function. So because of that, we have to have our knowledge and we have to show them our, the people, the other consultants, that we are knowledgeable and the skillful people to manage our patients at the first contact care, right? Not at secondary care. So because of that, it's very important for you all to have the discussions like this. Okay. Any other problems about this patient or any other regarding this related to topic? Let me know. You can ask.
Madam, another question in the chat box. When can we stop thyroxine therapy? Its normalization of TSH level sufficient?
No, because whenever inflammation is going on, right, most of the time, and during to some age, about, we'll say 5 to 6 years, 7 years, 8 years, like, you need to monitor this patient, right? Definitely. And most likely can't stop, but the doses can be reduced. And at some stage, because whenever such patient is going to be old, and then the metabolic rate side, the metabolism has been slowed down according to the body's atrophy and these things. In such case, you can tailor-made to the dose by reduction of the dose. And sometimes, if it's for about, the nearly it's going down, we'll say that 25 microgram is the minimum dose of thyroxine. With that, the TSH is also going towards, hyperthyroid state වගේ පේනවා නම් විතරක් we can think of, the tailing off this one, but it's very unlikely, right? Once the hypothyroidism is being diagnosed, need to have the lifelong treatment most of the time. That is my clinical experience and the guideline. That is autoimmune, no? So because of that, it's beyond our control. That is why monitoring is being needed. Importance of monitoring to check the what status of, the thyroid function, thyroid gland to produce the hormone now. So it's very important thing is the correct, monitoring of the patient. What else?
Madam, Chaminda here.
Yeah.
Madam, in a hypothyroid patient, after we done lipid profile,
Yeah.
At what level we can start atropine, in which high level, madam, high risk level, madam? I
No,
mean,
that is this, right? Guideline, yes. According to the lipid management guidelines, right? For a patient, with usually other comorbidities, they have given different guidelines of two levels of, that is more towards the cardiovascular risk, to prevent that, we are thinking about. So we assess the patient according to the CVD risk assessment chart. And then we are going to put the patient on according to that, the atorvastatin dose, right? So the low dose, the moderate dose, the high dose, the killer, we'll decide from that. But for an example, we'll say CVD risk patient, කියලා එයාට CVD established CVD එකක් තියෙනවා, we straight away go for the highest dose නේ, high dose නේ, එතකොට 40 යනවනේ අපි, like that. But here, if the patient is hypothyroidism and her cholesterol level, the dyslipidemia level, LDL target, right, must be within the safe level, right? So we have to, thinking about other comorbidities, it's a different story. We'll say that patient doesn't have any other thing here. With hypothyroidism, once we get corrected, the lipid control also will come, right? So in such a case, at least api CVD risk එක assess කරාම normal කියමු, but assessment of CVD risk also, it's a must for such patients. But even though the risk is minimum, we have to start with 10 milligram, right? Because we'll say the lipid profile says that LDL level is, at least LDL level need to be around 115 target.
Yeah.
Clear? 116, ne?
16.
Yeah.
madam.
116. Clear?
That's mean, madam, it is more than
Not clear, Nediya, ඔයාගේ line එක.
116 until the TSH starts
Yeah.
at least 10 milligram of atorvastatin.
Yes,
Hello?
because
Madam,
106.
can you hear me?
Now it's disturbing. Anyway, it should be around 116 or below, right? So always you need to maintain that level. For that, you can adjust if the patient is so much, the keen about the diet, right? And, the thyroxine minimum, with the correction of thyroxine, it will come to the normal as well. So diet and the correction, till that, if you go that, and in 3 months time, you are going to repeat the lipid profile, or after starting treatment, whether you are going to, get this target level kela. So in such case, right, if it's, we'll say that the thyroxine, with the initiation of the thyroxine lipid profile, the LDL is around above 115, we'll say. And once you assess the CVD risk, that also less than 10, we'll say. Then you have to start, the atorvastatin 10, right? But we'll say that her LDL level is 160, okay, 160 or 180. And with, the CVD risk is minimum. So in such case, you can, start with 20, right? But once you check it in after 3 months time, it has achieved the dose, right? It's more than expected low. Then you can, reduce to the 10 and go ahead. That is monitoring. But anyway, you need to start without, the thinking about the CVD risk. And lipid profile is a must for you all to start that. Got it?
So, madam, you want to continue 10 after the thyroid functions and lipid profile coming to normal?
Yeah, once it's, why? Because our target is to get the proper control of with the metabolism, right? By replacing thyroxine, right? Once the thyroxine comes into the effectiveness, right? Effective management of the metabolism, then the lipid metabolism also will be under control. So the once you check it after 3 months time, it has achieved the target, right? With the 20, we'll say it's marginal achievement. අපි කියමු 116 target තියෙන අපි කියමු 114 වෙලා. හරිද? එතකොට then you can go ahead with the same dose, and in another 3 months time you can check it again. If it's going more lower, then you can reduce to 10. Even after, the thyroxine correction එකත් එක්කත් Even though it's just below 140, 10 වලට ගිහිල්ලත් බලන්න පුළුවන්, provided that patient doesn't have any other, the comorbidities or the family history of, the young, this premature heart disease වගේ දේවල් නැත්තම්. That depends on the patient-centered management. But you have to continue that, the atorvastatin or the statins with the, at least the dose that necessary according to the patient's lipid profile.
Okay, thank you, madam.
Any other question? හැමෝම සන්තෘප්තයි නේ, ප්‍රශ්න එහෙම අහන්නේ නැහැ. ඔක්කොම දන්නවා. නේ? That's really good. And thank you very much for your kind support, for appreciating us, our service that me and Dr. Lalantha, and we will there for sure for you all to guide you all to the correct, the path to become a consultant family physician with competence necessary to be, the equally, the serve to the country with other consultants, to as specialist, the skillful specialist in first contact care, not in any other specialty. So thank you all, all for joining, and all the very best. Right? If you all have some presentations while during your attachments, Thursdays are open for you all to go with me. So far I have done with my, the trainees, but next time also Inisha will do the discussion, because we discuss the case-based management so that you will realize what is the importance of holistic approach in history taking through proper doctor-patient relationship establishment, and the importance of, the skills in, the assessing the clinical examination to detect red flag signs as well as the other signs, and then to do the counseling skills, and to achieve the best patient-centered the management to address the causes that you have found from the history taking. So that is the correct management in primary care according to the best evidence-based knowledge. So shall we wind up then?
Okay, madam.
I hope that you all have got, some knowledge from this Suvimali's presentation, and clarified some of the doubts that you all have with my discussion. So I am really thankful to the Suvimali for doing a hard job, for going through the lot of reading and coming with, the sharing your knowledge to your colleague. So always I'm telling you, the unity is the strength for good things, not for bad things. So keep your unity among the discipline of family medicine, because there are a lot of, the hardships ahead. So because of that, unity to improve your skills, right? So go ahead like this. So thank you very much. All the very best and good night. Suvimali, again, thank you so much.
Thank you very much, madam. And this, I would like to thank the Sri Lanka College of Specialist Family Physicians for giving the opportunity to present this my presentation. And thank you, Prabhat, and all the colleagues who participated. Thank you, madam. Good night.
Okay, thank you. Thank you. Good night. Thank you, all the members of the college. Thanks.
Thank you, madam.
Thank you, madam. Good night.
Thank you.